So let's start discussing the today's topics. Like many of you had requested ECG revise karna hai last minute wala. So quickly let's revise the ECGs first, then few more images. So today's session 3 is predominantly image based. Okay, so tell me that what do you think is going to be the answer for this one? Okay, in the today's session, that's the last session, session 4, I'll try to cover a lot of one-liners based on your PYQs, right? So it's going to be like a rapid fire revision of the PYQs in the form of one-liners. That's what I'm planning. Okay, very good. What is the treatment of choice? Very good. All of you have got this right. It's going to be cardioversion. Why cardioversion? Because the patient is unstable, right? Always keep in mind that when the patient is unstable, right? When the patient is unstable, you do not waste time and you directly go for cardioversion. What is the diagnosis here? This is PSVT. Absolutely right. The image here is showing PSVT. Why is it PSVT? Remember, supraventricular tachycardias, they have narrow QRS. That's how you differentiate supraventricular from ventricular tachycardias. Okay. When you see a narrow QRS complex and you have, how is the rhythm here? The rhythm is a regular rhythm that you are seeing here. Right, it's a regular rhythm. There's tachycardia and you see narrow QRS complex. The P wave is getting hidden here in the QRS complex itself. Regular rhythm, absent E wave, it's going to be basically your cardioversion. Okay, is this clear with everyone? This is very favorite question for the exam. PSVT ka ECG, narrow QRS, regular rhythm, very important. If the patient is stable, then you would do vagal maneuver, and if it is not responding, then you go for adenosine. And also remember, if adenosine also is not working, then what is the next drug that you give? This is one of the NICT PYQs. पहले आप करते हो वेगल मैन्यूवर्स, राइट, देन आप करते हो एडिनोसिन आईवी देते हैं. अगर एडिनोसिन भी काम नहीं कर रहा है तो yes, if adenosine also is not working, then what is the next drug that you give? So look at the flow chart here. PSVT, if the patient is unstable, you directly go for cardioversion. Unstable patient is basically blood pressure less than 90/60. Okay, blood pressure less than 90/60 is what is unstable. Okay. अब्लेशन कहाँ पे आता है रश्मि? डू नॉट गेट कंफ्यूज. अब्लेशन मतलब सोचो हम किसका अब्लेशन करते हैं? एक्सेसरी पाथवे का अब्लेशन करते हैं. वो कहाँ होता है? वो होता है WPW सिंड्रोम में, जब बंडल ऑफ केंट है, राइट. सो रिमेंबर, इफ द पेशेंट इज स्टेबल, you go for Valsalva's or carotid massage. If it is still persistent, then you go for adenosine. And if there is still after adenosine, then you give CCBs. Calcium channel blocker is the next drug after adenosine that you give. Okay, so the next drug that you give here is calcium channel blocker, right? And remember, for adenosine, what side effect do you remember? What side effect can adenosine have? Remember, it can cause bronchospasm. Okay, bronchospasm is what it can cause. So it is contraindicated in asthmatics. Asthma wale patients mein aap nahi doge. Okay, now look at the image here. So this is a narrow QRS complex. So this is going to be PSVT. And look at the complexes here. How are the complexes here? These are broad QRS complexes. This is going to be ventricular tachycardia. Okay, keep this image in mind. Ventricular tachycardia is the broad QRS complex. Supraventricular is narrow QRS complex. Whenever you are given an ECG image like this, try to look at the lower, the long lead 2 at the bottom. You can see that there are broad QRS complexes which are regular. This is going to be ventricular tachycardia. Okay, this is basically ventricular tachycardia. Is this clear with everyone? Right? Is this clear with everyone? Right. Okay. Going on to the next one. This is a very favorite ECG image. I've tried to put the most important, like, the frequently asked ECG images. What are you seeing here? Look at the ECG image here. Waxing, waning जैसा है, waxing, waning जैसा है. Basically, जो twisted ribbon होती है, you have a ribbon and you try to twist it. It goes like this, right? So when you have this appearance here, this is going to be twisted ribbon is Torsades d pointis. Torsades d pointis. Remember all the hypoelectrolytes, hypokalemia, hypocalcemia, hypomagnesemia, right? Hypokalemia, calcemia, magnesemia basically will precipitate Torsades d pointis. What is the drug of choice here? Very important question. What is the drug of choice here? The drug of choice here is IV magnesium sulfate. Okay, we give magnesium sulfate here in Torsades d pointis, right? It is also called polymorphic ventricular tachycardia. Okay, and what predisposes to Torsades d pointis? It's going to be long QT. Long QT predisposes to Torsades d pointis. Okay, Torsades d pointis. Long QT predisposes to Torsades d pointis. Okay. Right, and which antiarrhythmic drugs? Class 1 and class 1A and class 3. Okay, they precipitate Torsades d pointis. Remember Torsades T for 3. Class 3 drugs and class 1A drugs precipitate. So amiodarone is included in class 3, but remember out of class 3, amiodarone has the least chance of causing Torsades d pointis. Okay. Alright, look at this one. What are you seeing here? A prominent U wave. Very, very important question. Where do you see a U wave? In which electrolyte abnormality? Where do you see a U wave? In which electrolyte abnormality do you see a U wave? So, easy trick to remember is U for under. Okay, UK. Remember U for UK, that is under kalemia, that is hypokalemia. Okay. So, what causes U wave is hypokalemia. Always remember that UK under kalemia is U wave. Okay, U wave. And what do you see here? What do you see in this ECG here? What electrolyte abnormality? Look at the T waves here. Look at the T waves here. What are the T waves looking like? Tall, tented T waves. Okay. Remember, T is the repolarization, and the repolarization is because of potassium. So, increased T basically means increased potassium. That's going to be hyperkalemia. Okay, hyperkalemia. And when this becomes severe hyperkalemia, you get sine wave pattern. Remember, sine wave pattern is seen in sign for severe increased potassium. Okay, severe increased potassium more than 8, that is when you get sine wave pattern. What do you use for treatment of hyperkalemia? If there are ECG changes present like this, the first thing is stabilize the heart. So what do you give is calcium gluconate is what do you give to stabilize the heart first. It does not decrease the potassium levels, but it stabilizes the heart, reducing arrhythmias. Okay. Right. Then you have insulin, salbutamol, potassium binding resins that are given. Okay. So remember, this is sine wave pattern. This is hyperkalemia and you have tall tented T waves. Very, very important. Going to next one, atrial fibrillation and atrial flutter. Fibrillation means the atrium is not contracting. The P wave is going to be absent, and very, very important. It's an irregular rhythm. Patient starts feeling the palpitations, then there is syncope, right? And there is irregular rhythm. You do not see a baseline, right? Baseline hi apne dekhte irregular rhythm hai. This is atrial fibrillation. Okay, this is atrial fibrillation. What do you do here? What do you do in atrial fibrillation? Rate control, rhythm control, and you have anticoagulant also, which is given. Always remember, for atrial fibrillation, what anticoagulant do you use to prevent the stroke that can occur because of atrial fibrillation? Yes? Yes? What drugs do you give as anticoagulants? Remember, you have two options, that is the newer oral anticoagulants or the older one, which is warfarin. Right? Generally, what do you prefer is the NOACs, newer oral anticoagulants. Okay. When do you give warfarin? Remember important points. Warfarin, WA is VA. Anything which is valvular related. If the atrial fibrillation is because of a valvular pathology like mitral stenosis, rheumatic heart disease, or it's a prosthetic mitral valve. If it is related to a valve, then you give warfarin. Otherwise, you give NOACs. Which are the NOACs? Which is the oral direct thrombin inhibitor? Which is the oral direct thrombin inhibitor? Very, very important question. Which is the oral direct thrombin inhibitor? Oral, which is given directly oral, that is dabigatran. Remember, dabigatran TR is thrombin, AN is antagonist and it is given direct oral. Plus, which are the other drugs given orally? The direct factor 10A inhibitors like rivaroxaban, apixaban, right? XA banning drugs, the factor 10A banning drugs which are acting on factor 10, right? So, you have factor 10A inhibitors and oral direct thrombin inhibitor, that is dabigatran, which are given, okay, to prevent the stroke. What score do you use here? Chad's-Vask score, which tells you that what is the risk of stroke and whether we need to give anticoagulant or no. Okay, and you give for rate control, rhythm control, and then you have cardioversion, chemical cardioversion, which is the drugs basically that you give, or you give a shock wala. Okay? And remember that rate control में हम कौन से drugs use करते हैं atrial fibrillation में? जब rate control करना है from the atrium to the ventricle, basically you are giving AV blocking drugs. A, B, C, D. AV blocking drugs are beta blockers, calcium channel blockers, and digoxin. Will you use lignocaine here? No. Lignocaine is not used because lignocaine only acts on the ventricle, not on the atrium. It does not act supraventricular, right? Lignocaine acts better on ischemic myocardium, so it is given MI wale arrhythmias mein, acute arrhythmias mein. Okay? Is this clear with everyone? Yes, for rhythm control, you do give Electrolyte. Right? Rhythm control ke liye you have Electrolyte, amiodarone, which is given. Okay? Right. And look at atrial flutter is comparatively more regular rhythm, and you have the sawtooth pattern that you have in atrial flutter. Okay? Sawtooth pattern in atrial flutter. Going to next one, multifocal atrial tachycardia. The most important clue in the question here will be a patient who's a COPD patient, asthma patient, COPD patient, ये history रहेगी, and you are given this multifocal atrial tachycardia. Atrium से आ रहा है, मतलब क्या abnormal होगा यहाँ पे? P wave multiple morphologies की होगी. Okay, look at the various P waves morphologies that are shown here. At least 3 different P wave morphologies. What you have here in multifocal atrial tachycardia, history of COPD is very important here. Okay, clear with everyone? Coming to pulmonary embolism, the most common ECG finding that you have with pulmonary embolism is sinus tachycardia, right? There's tachycardia that you see. And the most specific sign is this S1Q3T3 pattern. Okay, in lead 1, the S is prominent, then you have Q and T inversion basically present in the lead 3. So, S1Q3T3 pattern, that is Magdalen-White sign, is what is seen in pulmonary embolism. Okay, S1Q3T3 pattern. Coming to next one, the degrees of AV block, right? When the AV is getting blocked, so basically the time required for atrium to ventricle conduction increases. So you will have this will be presented as long PR. Prolonged PR is the first thing that you would see, right? More than 0.18. Okay? Palas and Hampton, Taranum, remember those are the chest X-ray signs of pulmonary embolism. Okay, those are the X-ray signs. So prolonged PR is what you see. How do you calculate PR? From beginning of P to beginning of QRS. ठीक है, beginning से beginning basically ये है आपका PR interval. The PR interval is prolonged in first degree. Okay, in first degree only there is increased PR. In second degree AV block, remember second is do matlab dropped. ठीक है, dropped beat is going to be present. What do you see here? R दिख रहा है यहाँ पे, फिर यहाँ पे basically drop हो रहा है. ठीक है, P followed by QRS, P followed by QRS, and after a P there's a drop which is present here. Whenever a drop is present, it's a second degree AV block. Okay, so in second degree basically you have Mobitz block. Okay, Mobitz, remember Mobitz is bi, that means it's a second degree block. You have Mobitz type 1 and you have Mobitz type 2. 1, remember Mobitz type 1 is a Wenckebach phenomenon. So where do you see Wenckebach phenomenon? In 1 is Wenckebach. Okay, so the PR interval here increases progressively and finally there's a drop. Okay, पहले इतना PR है, फिर इतना PR है, फिर इतना PR है और फिर drop आ गया. While in Mobitz type 2, it's a constant PR prolonged plus there's a drop present. PR prolonged, PR prolonged, PR prolonged. After a P, there's a drop present. So what is the difference between first degree and Mobitz type 2 is In first degree, there is no drop beat. In second degree Mobitz type 2, there's a drop beat also present. So if a drop beat is present, then you will call it second degree. Third degree complete heart block means atrium अपना कर रहा है, ventricle अपना कर रहा है, the PP is constant, the RR is constant. But they are independent of each other. P can come before QRS, after QRS, merging with QRS anywhere, right? So the RR is constant, the PP is constant, and they are independent of each other. The P is coming after QRS, the P is coming before QRS. ये दोनों अपने हिसाब से चल रहे हैं third degree block में. Okay, the RR is constant. Okay, it's regular in third degree. Okay, that is what you should remember here. Is this clear with everyone? Yes. Okay, so this is about the AV blocking, the AV block that you have here. Going to next one, coming to some important waves that you have, extra waves in ECG. This is the Osborne wave. जहाँ QRS खत्म हो रहा है वहाँ पे एक और wave आ रही है. So at the J point, Osborne O, remember, is seen in hypothermia. Okay, it is seen in hypothermia. What wave are you seeing here? This was asked in the recent NEET PG 24 exam or INICT exam, one of the recent exam. Okay, so when you see something like this after the QRS, okay, ऐसे E जैसा कुछ दिख रहा है, this is called as epsilon wave. And where do you see epsilon wave? Remember, epsilon, ear epsilon is seen in ARVD. Arrhythmogenic right ventricular dysplasia, where the right ventricle muscle is replaced by fibrofatty tissue, becoming arrhythmogenic. So remember, epsilon wave is ear, it is seen in ARVD. Okay, it is seen in ARVD. Look at this, look at the QRS going like a sloping one, like a slanting line, right? This is basically called as delta wave. Delta wave is seen in WPW syndrome, where you have accessory bundle of Kent, which is faster conducting as compared to AV node. So how is the PR here? PR is going to be short क्योंकि ये faster conducting है. How is the QRS going to be here? QRS, you can see, is going to be broader because it's an abnormal pathway. It's going to be broader. Okay, the PR is going to be short, the QRS is going to be broad, and it's going to have this delta wave. Remember that here in WPW, you do not give drugs which cause AV block. You have AV node, you have bundle of Kent which are competing to pass the signal. If you block the AV, so this is getting the dominance, right? So this is winning. You do not want this to happen. So do not give AV blocking drugs here, like digoxin is not given, okay? And yes, what do you give as procainamide? Correct. Right, is this clear with everyone? And what is going to be the definitive treatment for WPW syndrome? The bundle of Kent is the problem. तो वो bundle of Kent को उड़ा दो, basically उसका क्या कर दो? Ablation कर दो, ठीक है? Ablation of the bundle of Kent is what is the definitive treatment here, right? Clear with everyone? Coming to MI, how do you localize its anterior wall, lateral wall, inferior wall, right? So how do you keep the leads as V1, V2, V3, V4, V5, V6, right? That's how it goes. So if this is the heart here, so basically ऐसे start होगा V1, V2, V3, V4, V5, V6. So V1, V2 जो है ये है enteroseptal, ठीक है? V3, V4 apical में आएगा, V5, V6 lateral में आएगा. Now in the inferior MI, remember inferior of the body is the foot. So AVF, which is towards the foot, 2, 3 AVF is inferior wall MI. AVL, L is for lateral. Okay, AVL, L is for lateral. Okay, is this clear with everyone? In the posterior wall MI, you would see reciprocal changes in the anterior wall leads. Right, V1, V2 will show ST depression in posterior wall MI. Okay, so if there is V1, V2 depression, you can think of posterior wall MI. Clear with everyone? Okay, so look at this one and tell me that what wall MI are you seeing here? What wall MI are you seeing here? Very good. Correct, Sharavali. I'll come to that. So look at this. This is 2, 3 AVF. Okay, 2, 3 AVF, like जैसे foot वाला shape होता है. ये वाली जो leads है यहाँ पे, इसमें you can see the ST elevation like a tombstone appearance. Okay, tombstone appearance, Pardy sign, that is what it is called. It is inferior wall MI, which is because of right coronary artery. Inferior wall MI, right coronary artery, supplying the SA node and the AV node also. So when that gets affected, remember this MI will have bradycardia, it will have hypotension that's going to be present, but there's going to be bradycardia here instead of tachycardia. Okay? And in the treatment, you give your IV fluids, you give atropine. ठीक है, जो पैरासिम्पैथेटिक सिस्टम ओवर एक्टिवेट हो रहा है उसको ब्लॉक करने के लिए आप एट्रोपिन दे रहे हो और आईवी फ्लूइड्स दे रहे हो. रिमेंबर, वेरी वेरी इंपॉर्टेंट. ओके, वेरी वेरी इंपॉर्टेंट. Right. And so inferior wall MI is because of generally the right coronary artery, which also supplies the posterior wall. So generally they come together. Okay. All right. So this is your few, assessment questions here. Tell me, what do you think will be the answer to the first one? 60-year-old woman taking furosemide is noted to have U wave. What is going to be the answer here? U for UK, underkalemia. So that's going to be hypokalemia. Okay, the answer is going to be A. Is this clear with everyone? Then you have man presents with fever and chest pain, angina hai. There is concave elevation of the ST segments in leads 2, V5 and V6. What is the answer to this one? What do you think will be answer to this one? Yes. Okay, Shri, I'll come to that. Okay, is this a lateral wall MI? अगर lateral होता तो ABL में आना चाहिए था, lead 2 में आ रहा है, V5, V6 में आ रहा है, ये तो कोई territory में fit ही नहीं हो रहा है. Brugada is going to be lead V1 and V2, coved ST segment elevation. Very good, Sheravali Tarannum, correct. This is pericarditis, guys. Look at the question. This is where we make silly mistakes. It is concave elevation of the ST segment. Remember, ST segment elevation, when it is there, you need to think of two possibilities. One is MI, one is pericarditis. At least itna to aapko sochna hai, ye do possibilities. MI is a sad event, right? And pericarditis is a better event. So remember that MI sad phase हम कैसे बनाते हैं? ऐसे बनाते हैं. It is convex elevation. Pericarditis कैसा है? Better event है. It's a smiling one. It's a concave elevation. So concave elevation, not confining to any territory. This is going to be pericarditis. Okay, this is not MI. This is pericarditis. Is this clear with everyone? ठीक है? Yes. Going to next one, S wave in lead 1, Q wave in lead 3 and T wave inverted in lead 3. So this is S1, Q3, T3. What is this going to be? This is going to be pulmonary embolism. Okay, this is going to be pulmonary embolism. Next question. Tell me, what do you think will be the answer to the question number 4? Undergone thyroidectomy, has ECG with QT interval of 0.5 seconds. What is this? थायराइड के साथ हमेशा याद रखना कि थायराइड के बाजू में पैराथायराइड होता है, एज द टर्म सेज. सो पैराथायराइड भी निकल गया तो कैल्शियम कम हो जाएगा. सो बेसिकली दे आर पॉइंटिंग टुवर्ड्स हाइपोकैल्सीमिया. Right? And what does hypocalcemia do in the ECG? Calcium is required for heart contraction. No calcium, everything is becoming slow. So prolonged time, the QT increases. There is prolonged QT that you are seeing here. Okay, so 0.4 से ज़्यादा है यहाँ पे, 0.5 है. It's a prolonged QT. Okay, long QT, hypocalcemia causes long QT. Next one, interesting question. A woman who presents with hoarseness of voice, pulse rate 44 है, ECG में भी bradycardia है, and there is reduced amplitude of PQRS and T waves in all the leads. What is this? Yes, what is this going to be? And you have the options here right in front of you. So look at bradycardia. Look at hoarseness of voice. look at, the decreased amplitude. No. Very good. This is hypothyroidism. So basically myxedema that is coming here. This is hypothyroid K features. Remember hypothyroid, there's bradycardia, right? And there is basically, what are you seeing here is pericardial effusion is what you see with hypothyroidism. Pericardial effusion. And because of this pericardial effusion, there is going to be decreased amplitude. Okay, decreased amplitude of the waves that you are going to see because of pericardial effusion. Is this clear with everyone? Right? So that was about the quick review of ECGs, guys. Remember PSVT, Torsades D pointus, atrial fibrillation, U wave, tall tented T wave. This is what is generally asked. Yeah, this is something that we missed here. What are you seeing here? What is this ECG showing? Q, right? You have Q, R, and then you have this ST, which should have been isoelectric flat line. So what is this image showing here? This is showing ST depression. Okay, remember this is ST depression. So remember ST depression, digitalis is what shows ST depression rather than ST elevation. Digitalis का आपको कैसे याद करना है? Remember PR. PR for PR, it is prolonged. QT becomes choti, that is short QT because it increases calcium. ST becomes depressed. Depressed ST rather than ST elevation. So you have this hockey stick sign, tick mark sign, or like this mustache wala sign, which is Salvador Dali mustache sign. Okay, PR prolonged, ST depressed, QT choti, and T becomes ulti. That is inverted T wave is also what it can show. The most common arrhythmia that it can also lead to arrhythmia, right? So remember, it can lead to ventricular bigeminy is the most common arrhythmia that you see with digoxin. Okay, ventricular bigeminy. Okay, clear with everyone?